Growing tidak yes. Hierarchy.
Shall we start?
Yeah, please.
Okay, sure. Thank you. A very good evening to all of you. Dr. Ramesh, good morning to you there in US. Uh, we at Medtronic would like to welcome all the participants for learning webinar. Uh, First and the foremost, we would like to thank you for uh, all the efforts which you have been taking during these difficult times for the safety of the community. Thank you so much. And as we all know from the agenda, today we have the program leaders as Dr. Sreenivas Kumar and Dr. Ramesh Jagupati. Uh, it's our privilege and honor to as a program leader. I would like to introduce Dr. Srinivas Kumar, which is an honor and privilege for me. We all know Dr. Srinivas. He doesn't need an introduction. He is the Director Cardiology at Jubilee Hills, Hyderabad. Sir is a founder director at Facts and the founder director at PCB India. More importantly, an invited faculty of the national and international congresses. And we all know him for his groundbreaking work, especially in a complex angioplasty and structural heart. Thank you, Dr. Srinivas Kumar, for accepting our request to be a program leader for this academic session. Over to you, Dr. Srinivas.
Yeah, good evening, everybody. Thanks for your kind words of introduction, Anand. We wish we could live up to those. And then probably we should be extremely thankful to all our colleagues across in the country. And then my special thanks to Dr. Ramesh Dagupati, is a good friend and is always ready to do any sort of help in any program organization. And as usual, he was always ready when we requested for him for this. Thank you, Ramesh. And I wanted this session to be also like a curtain raiser for coming TCT India meeting, which you're planning like not only India with South Asian countries together too. I thank all the colleagues, cardiologists across who have joined here from other countries too. Dr. Vinto from Myanmar, and Dr. Saidur Rahman from Bangladesh, and Dr. Pandula from Sri Lanka, and then Dr. Chandrana for Chandra from Nepal, and we also wanted two of our India colleagues to be there, Dr. Rahul from Mumbai. In spite of very odd situations in Mumbai, he still did it. And that is a passion which we have. And Dr. Sarita will be also joining from Indore. So the topics we thought what we'd have today is instead of having a routine lectures, which have become too many in these webinars and this serious nature of COVID and various other things, we thought we would have it more like interactive sessions with some interesting cases, and that's why we titled it as Cardiac Conversations and India and South Asian countries together, and we'll have some interesting case presentations in between. And as Medtronic now, because of Resolute Onyx and Onyx study, and then now probably because of more interest happening in the high bleeding risk scenarios, we also thought it as a high bleeding risk summit. So before I request the presenters to go and present the topics, I'd briefly introduce what is this high bleeding risk. Can can you see my slides? Okay, I will not present with too many slides. This is again introduction about our program, the teaser, which is being done. Best wishes from Apollo Group of Hospitals. My fax professionals colleagues, again, I'm very happy because whatever programs we did is extremely cooperate, and all such meetings are possible with everybody's help. In be it be taking care of patients or be doing any such meetings, and very happy to have their all their help in these tough times of COVID. Again, it's all the more important to work together, and we cover these multiple hospitals. Again, we help each other in these difficult situations, and that's how the patients are being given a better care. Now with this, I also have opportunity to talk to my colleagues in Apollo, in Mumbai, Indore, and many other places too. Back to our topic today, the high bleeding risk. What we are calling is basically 30 plus academicians and good scientists met together, and then in the 2019 mid, they have designed what are these high risk features. All of us knew what are these, but they are properly tabulated and made it in one major and minor hybrid bleeding risks. As we all know, in the day-to-day practice, as we keep doing more complex cases, we come across more elderly people with such of comorbidities. The aging is one important thing as we all population ages, and renal disease, liver disease, cancer, these are comorbidities, anemia and low platelet counts, and stroke, bleeding diathesis and platelet disorders, bleeding diffusion. And then patients on oral anticoagulants, especially patient has associated atrial fibrillation, usage of steroids, and then probably patients who are due for surgery. These are some of the things which are. But if you have to see which are the major ones and which are the minor criteria, all those which are listed dark blue, but for these two are labeled literally wrong. And long-term oral anticoagulation usage, low platelet count, bleeding diathesis, liver disorders, active cancer, and due for planned surgery, and then stroke and AV malformations and bleeding history of bleeding recently, recurrent especially in 6 months. Anemia, hemoglobin of less than 11 is considered as major. In between 12 and 13 is again minor. Renal disease, GFRs of less than 30 is major, less than 60 is minor. And age and NSAIDs again is taken as a minor criteria. So when do you consider a patient has a high bleeding risk? This is what is shown. Is basically they have decided that if a patient has a 1 year risk of getting into trouble more than 4% of a major bleed, that is BARC criteria of 3 to 5. BARC is again, as you know, bleeding ARC criteria 0 to 5, from simple to more complicated, 5 being fatal. And more than 1% risk of intracranial bleeding. If any patient has this much of risk, he is considered as a high bleeding risk candidate. So these are the who falls into that what I've shown before, one major or two minor criteria. If it is there, they are taken as high bleeding risk population. Generally, in day-to-day practice, they are supposed to be constituting about 1/3 to about 40% of patients. And most commonly, we may see these are more commonly than all others. Elderly age, anemic patients, and the patients on oral anticoagulation and CKD and liver disorders is one of the registries showed that. So this is how I thought we can discuss more about the Onyx global study and other things, which later in the end Dr. Ramesh would present. So these are the subset of patients in which we are dealing with in today's day-to-day scenarios and how to tackle what care needs to be taken, and all those discussion we can have more in the panel discussion. Now we will go on to the case presentations. Individually, we thought we could reflect some of these high-risk clinical scenarios, and some of the cases would have it, and some could be more interesting cases depending upon the presenter's interest. And we'll now go on to the case presentation, and then come back again for the last Onyx presentations. Before we go on to presenters, I would request Dr. Ramesh to say a few words, and then we'll go on to the presentation by Vinto. Dr. Ramesh?
Dr. Sreenivas, thank you very much, and thanks to Medtronic for sponsoring on the webinar, and all the panelists. I think this is really a great need to address high bleeding risk. Somehow we do not pay attention to calculation of the bleeding risk score or the BARC3 high bleeding risk assessment of these patients. So in the United States now, we completely moved in our institution to actually 80% of our usage is the Onyx based on, because we don't know which patient is going to bleed. So with that, I think thank you very much for having me on this webinar. We will further discuss after all the presentations, and I also thank your leadership in getting all the panelists and from different parts of the countries in Southeast Asia.
यस्तै कुरो गरौँ एउटा ठाडोलाई गरौँ हुन्छ
You're muted, Dr. Sreenivas. Dr. Sreenivas, you're muted.
Yeah. Thank you, Ramesh, for your encouraging words again. And we request all others to mute their mics. As thought, given in the program list before, we will have a first presentation by Dr. Vinta. He's a senior interventional cardiologist, good friend of ours. In the early way back, decade back, he was also trained with us in our earlier institute. Now he's a big man in Myanmar. He was actually president's cardiologist. Now he does a lot of good things there. And when we go there to inaugurate the lab, and he has introduced the situations, to do very good work there. He made us very proud, and his word is final in Myanmar. And thanks for accepting our invitation, Dr. Vinto. And we are expecting to see and hear a good case from you. He has selected one interesting case. Normal coronaries is okay. Normal coronaries with some peculiar problem he would like to show. Over to you, Dr. Vinto.
Okay, sir. Thanks for your introduction. Actually, I got contact with Dr.A.Sreenivas Kumar just yesterday, so I don't have enough time to explain. So, but a very good case, young man presented with the acute coronaries.
Dr. Vinta, the presentation rights are there with you. You can share your desktop now.
Yes. Now you can see my desktop.
No, we are not able to see your desktop. You need to share it.
Okay, I'll try.
Yes.
Now you can see.
Yes.
Okay, thanks. My case is two gentlemen presented with the typical central chest pain. Is cardiovascular risk factors 7 factors: chronic smoking and hypertension. Comorbid conditions is chronic alcohol. This is his admission ECG. As you see, significant ST elevation MI in the 2-3 AVF and the complete heart block. So we arranged for the emergency coronary angiogram with in mind to do the primary PCI to the culprit vessel. We then through the femoral approach because of maybe the possibility of the temporary pacemaker insertion. So we choose the femoral artery approach. You can see that the left system is okay. We can see the myocardial bridging in the mid LED. Second flash is also okay. Yeah, done. Next. Yeah, done. Next. Do the angiogram to the right system. You see that stasis of the contrast inside the vessel, even after I think stasis of the staining of the contrast, I can see only 15 to 20 seconds after the injection. No obvious obstruction in the right coronary artery as we expected. So, what is our next move? What is the possible cause of the patient presentation? Patient present with the inferior ST elevation MI and the complete heart block. So we expect the lesion in the right coronary artery. Now coronary is normal, no obstruction, but flow is significantly very slow. So initial thinking is that because of his young age, no obstruction, we thought that it might be the severe coronary artery spasm due to the illicit drug use, such as cocaine, amphetamine, like that. So we specifically inquire about the patient drug history after doing the procedure. The patient denied any illicit drug abuse, and the physical examination revealed no signs of the drug abuse. We also did urinary methamphetamine test, also turned out to be negative. Luckily, immediately after the procedure, patient relieved from the pain, and then ECG changed to the SC segment resolution. Yeah, we can see that, and then a patient got the sinus rhythm also. So despite the ECG improvement and the no more symptoms, the patient continued to have and still in the state of the cardiogenic shock. We still need to give the IV antitrobes. We place the patient in the CCU and then search for the cause of his strange presentation and monitor continuously. After that, credit work done by one of our junior fellows. One of our junior fellows performed the thorough history taking and the physical examination after the emergency situation, and he noticed systolic murmur. Then he carefully examined the transthoracic echo and found the amazing results. Actually, we do the transthoracic echo, but very quick bedside echo before the emergency procedure. This is portable echo findings. You can see that in these view, long person, long x-axis and short axis view, round echo dense 18 into 70 millimeter large mobile mass attached to the right and left coronary caps of the ear above. Yeah. From this time on, we have to consider the following differential diagnosis. Initially, we thought that there may be the severe coronary artery spasm due to illicit drug, but now it's not in the top of the list. And then another cause, infarctic endocarditis air above with the obstruction of the RCA by the myocardial aneurysm or vegetation. And then another cause is the ST elevation MI due to the temporary obstruction of the RCA or CN by the cardiac tumor. Actually, at that time, I thought that the infarctic endocarditis might be more favorable because of the very acute presentation. So our team impression is the infarctic endocarditis of the ear above first. Second is the cardiac tumor. So we perform the following necessary investigations. A white cell count is within normal limit. Yes, it's only 10. Blood culture 3 times negative before the introduction of the empirical IV antibiotics, and the histology, HIV, hepatitis B, C are the negative. But we treated empirically with the IV antibiotics, IV crystalline pan and the gentamicin. However, clinical features, blood culture results, and the recheck complete picture result did not favor the diagnosis of the infarctic endocarditis. So at the time, the possible assumption of the cardiac tumor became the top list of the consideration. At the time, we went to the heart team approach. We discussed our case with the cardiothoracic surgeon colleagues from the #1 Defense Services General Hospital, Yangon, because our hospital don't have the cardiothoracic surgeon colleagues. Then transfer the patient to the Yangon, our capital, for the subsequent management. They performed the transesophageal echo, and their impression is highly suspected for the more in favor of the cardiac tumor. The findings are almost same with the transthoracic echo. Actually, tumor is obstructing the right and the almost the left. The subsequent management is they open the open heart surgery and the safe excision of the mass. Because of the mass severely attached to the aortic valve and destroying the valve, so they can save the valve nature, and they did a metallic aortic valve replacement, and then some injury to the RCA ostium, so they did CABG to RCA with the one saphenous vein graft done. These are some photos and the video clips our cardiothoracic surgeon colleagues are doing. Both of the cardiothoracic surgeons are trained in the Care Hospital Hyderabad, I think 10 years back. There's the aortic valve leaf left and the tumor. Our patients, this is our patient, photo of our patient just 2 days after operation. Operation is very uneventful. He recovered very quickly. This is a histology findings. The report is a histology session showing the bland fibroblasts and the stem collagen surrounded by the endocardial cells. Areas of calcification present. The remark is the fibroma of the aortic valve. So our final diagnosis is the papillary fibroma of the aortic valve causing the RCA obstruction and inferior ST elevation myocardial infarction. This is a photo of our cardiothoracic surgeons and anesthetic colleagues. This is our cath lab team. Thank you very much for your kind attention, sir.
Thank you, Vinto, for sharing your interesting case. And this is a little unusual case. Most commonly in India, we also would see normal coronaries with recurrent appearance in MI sometimes. But that's why it also shows very important that doing a echocardiogram properly before taking up for patient, even if it is primary
Sure,
piece.
sir.
We used to insist in care also before that we have to do echo
Sure.
before. So it should have avoided some surprises. But anyway, finally you made it. And fibroma, the histopathological diagnosis came. That's how I think there's no further treatment required for the patient, and it's hopefully he should be doing well. Any comments, Dr. Ramesh?
It's a very exciting presentation, Dr. Minto, that you're able to detect. I think this patient probably the tumor might have been flopping into the right coronary artery, causing obstruction, and that probably explains why he had the ST elevation, and or a small speck of the tumor might have gone down the coronary artery and might have transiently occluded the coronary artery for some time. And obviously, I think you saved him by doing the echocardiogram. Otherwise, I don't think he would have even made it. It's very rare. I actually, to have to tell you the truth, that I've seen smaller papillary fibroelastomas in the aortic valve, but not of this size. At the age of 35, this is very unusual. Very good, very excellent way of detecting it and getting it taken care of. Congratulations.
Thank you, sir. Thank you, sir.
Congratulations, Vinto, for
Actually, in the very first time, I feel a bit guilty because of not detecting the case diagnosis in the very initial. But as a very emergency nature of the situation, we just check the regional wall motion abnormality at the time and then do the procedure. Finally, one of my junior fellows do the thorough job, and then finally we can save the patient. Thank you very much.
Srinivas, you want to go with the next presenter?
Yeah, so should I begin? Hello?
Yeah, we can see your slides.
Can you hear me?
Yes, we can hear you.
Yeah, okay.
Again, Dr. Gupta,
So,
please.
yeah. Good morning, Dr. Ramesh, and good evening to all other colleagues and the expert member, Dr. Sreenivas. So today, I'm just going to present this case is still in my hospital, was recently done. So I'll just go through the history and, it was apt to this discussion of high bleeding risk. So therefore, I chose to present this case. Now, this gentleman is a 71-year-old male, hypertensive, diabetic. He underwent a recent surgery for a oral malignancy at some other hospital, which was uneventful. But then there was a doubt of recurrence, and he was admitted to our hospital in our hospital for a revision surgery, hemimandibulectomy, which he underwent. And cannot move the slides. Hello.
You have the buttons on the left lower part of the screen. Arrow. You click on it.
Okay.
Dr. Rahul, you can escape and again go to the full PowerPoint presentation.
Okay, it's not getting.
Then only you can share your screen.
Now the mark has come.
Yeah, that's it.
Okay. Sorry for that. So his pre-op ECG and echo was normal. His hemoglobin was around 11.5. On the day of the surgery itself, 8 to 10 hours post-surgery, he developed severe chest pain with sweating and hypotension and mild LVF. And ECG was like this. It was suggestive of gross ST, significant ST leads with ST elevation in AVR. I did a quick screening echo and LVEF had deteriorated to 30%. He was started on NIV and inotropes, shifted to cath lab for immediate, angiography and intervention. Now, thoughts in my mind. Now, this patient has undergone a surgery. I asked my surgeon what is the prognosis of this patient. He said excellent, and you should be aggressive. So I thought I need to be aggressive. Now, my question in my mind was, should I load him with dual antiplatelets immediately? And there might be a risk of bleeding. But surgeon said that I will take care. And in case I need to send this patient for surgery, will loading help or should I do an angiograph? So this was the question, but I loaded the patient with dual antiplatelets with ticagrelor and aspirin because I knew that the surgeons will be hesitant to take such kind of patients immediately, and the surgeon, my oncosurgeon, was opinion that he will manage the bleeding. So this is how I went ahead with the case. This was the angiogram. The vessels, if you look at the fluoro itself, they are quite calcific, and it's a left dominant circulation. RCA was non-dominant and CTO, and it was less than TB3 flow. And the thought in the mind was, is this a thrombus? Is this a calcification with a thrombus? And all those thoughts. So this is the another spider view, and we can see some haziness and some disruption in the proximal LED, and the calcification also seen. This was the RCA, which was non-dominant and completely occluded. So thoughts in my mind were, what should be the strategy? Now, this patient is little hemodynamically weak. He has been on inotropes. Should I put an IVP first, or just try to open the artery first so that his hemodynamics would improve? Looking at the angiogram, it looked like that there is more of calcium. Thrombus is of course there, and this intervention might take time. We might not be able to achieve immediate flow. So I thought of deciding to put the IVP first. Usually, when these kind of scenarios, we have more of plaque rupture post surgery, and they have thrombus. You just aspirate the thrombus, and they are okay. But looking at the overall picture, and then the thoughts which were there in my mind, this patient, if he requires a rota because it looks like a calcific lesion, and if it is undilatable, so should I do a rota in a dominant circ in an acute cardiogenic situation, or just do a mild dilatation, improve the flow to the coronary, stabilize them a bit, and call the CVTS surgeon? So these were the thoughts which later on, maybe after the presentation, we would like to know from the members, expert members also, that how would they have approached. And if stenting, 2 stent versus provisional, 2 stents might be more complex. In case we need to stop DAPT later on, which stent? In case he needs repeat oncosurgery in near future, will I be able to stop antiplatelet? So these were the thoughts in my mind. I put an IVP immediately because I perceived that this would be a little tough. So as we see in this picture, the wiring of LCX was quite difficult. Gave different the curves and all, but still not able to go into the circumflex. So then now this is the picture which just shows that even the passing of balloon was difficult. The guiding was backing out when I was trying to push the balloon. So it gave the information that this is a calcific, eccentric calcification and with the thrombus. So finally did a low balloon dilatation with low pressures to make some space for wiring to LCX. I didn't want to do a high pressure, occlude the if there is a thrombus going into the circumflex. So these were the thoughts in my mind. And then I crossed into the LCX with the XTR. This is how the wire crossed. And then it was, after that, I did a little high pressure dilatation after securing the circumflex. This was the picture. Then passing to the balloon was also with mild resistance. It was not that easy. So this was into the circumflex. Then I changed the wire to the normal cyan blue wire, and then used a 3.5 balloon to LED. So the confidence which I got that probably this may not require debulking therapy was that the balloons were expanding well. So then I went with the 3.5 balloon, both in the LED and the LCX at this time, and did my first OCT run, because how do I proceed further? Whether this will require a dual stent strategy, single stent strategy, or maybe a cutting balloon. What is the kind of calcification which is there? These were the questions in my mind. These are the OCT images. This is a pullback from the LED, and if we look at the distal reference diameter and the proximal reference diameter, they are both same, because there was a post-stenotic dilatation of the LED, which was around between 4.5 to 5, and the narrowest area into the left main The area was about 4.3 millimeters square, and a calcific nodule with some thrombus could be seen in that area. But overall, there was not very extensive calcification. So I knew that probably I won't require a rotational atherectomy or any other debulking strategy probably in this patient. I also did a LCX to left main pullback, because in case I need to plan the strategy for the circumflex, I should have all the information ready. The image, the still frame images of the calcific nodule into the left main, but the ostium of the circumflex appeared to be fine. So all these OCT runs were to know where would be my distal landing site in case I need to plan a dual stent strategy. How is the circumflex? Probably I might get away. So if you look at, as we reach the circumflex ostium, it looks quite okay. And now we enter into the left main, and we have this the calcification and some thrombotic lesions. So I went with the 4.4 into 5, 22. No, once, sorry, this, yeah. So the Resolute Onyx was deployed at nominal pressure, pulled a millimeter back, and inflated at high pressures. And this was the image post that. Then I did a pot post dilated because I needed to exchange the wire. The left main looked like a 4.855 on the OCT. And so the pot was done, and then the wire was rewired across the LCX. And then we can see at the site of calcific nodule, at the junction, the confluence, we can see the under expansion of the stent. So I went ahead with the, after rewiring, the dilated with a 5O balloon. And this was the post stenting OCT pullback, and it basically showed the images that the distal part of the edge is still little under expanded. As we will go, the struts were not fully expanded, and as we enter into the area of the left main, there was asymmetrical expansion, as would be expected in a patient who has a calcific, eccentric calcification and nodule. So otherwise, the LED stent was looking well opposed. Only when we enter, there is asymmetrical expansion. So I went ahead, post-dilated the LED stent with 5O balloon at nominal pressure, went to the left main site and dilated at about 20 atmosphere with a 5O balloon. And this was the final picture. This was the final OCT run. We'll just go into the OCT run. And it showed that the distal edges were well opposed, and in fact, in the left main also, the stent was well opposed. The circumflex ostium looked okay from the left main LED to left main pullback. The only thing at the eccentric, the calcification part, there was some asymmetrical expansion of the stent. Otherwise, rest of the left main stent was quite, as we can see, it was little, asymmetric expansion. So otherwise, it was quite circular and good. And this was the final result. Now, the further clinical course of this patient: hemodynamic stabilized, anotrope stopped, and IBP removed in next 36 hours. LVF settled, his NIV was removed, ECG normalized. Bleeding in the drain from surgical site had increased a little bit. It went expected, but didn't require any re-exploration. This was the ECG immediately after the angioplasty. All the changes settled. But however, this patient now developed another issue. He developed AFib with fast ventricular rate. He was reverted with the amiodarone bolus and infusion. But then, however, he kept on having these short runs of AFib like this, which were there on the monitor, which eventually subsided. So now he's a diabetic, hypertensive, age is more than 70 years. So if we calculate the CHADVAX score, this falls into a high-risk group. Now, he's a patient who is a high bleeding risk, who has developed, who had a major recent surgery, and he's on dual antiplatelet. Now, what do we do? Should I start him on antithrombotic or antiplatelet strategy? So this was my case. It is a case more for discussion. Now, this patient is doing fine. He's scheduled for discharge maybe in a day or two, because he improved rapidly once the intervention was done, because it was as expected, because it was deterioration in the hospital and immediate intervention. So the questions which kept coming in my mind: if this scenario would have happened after a major intrathoracic, intraabdominal, intracranial surgery, which are not readily approachable site. Like for this case, the oncosurgeon said, don't worry about the bleeding, we will do whatever it needs to. But if it's a place, what should be the approach? Should we load these patients with antiplatelet? Should we just try to stabilize, send them for cabbage? So these are the questions which I would like the experts to comment about. And when these patients develop AFib, should I start anticoagulant? Because now this patient already had 2 antiplatelet, recent surgery. Adding an anticoagulation can definitely increase the risk. But I have not added because his rhythm stabilized and maybe it was the acute stress which triggered atrial fibrillation. And will stent type matter in this case? In case because this patient had a recurrence and he was reoperated, and the surgeon was quite confident that the margins were free and all on the frozen section. But then, if in case there is a recurrence, will and if you need to DAPT, can the stent type matter? And calcific nodule, which doesn't allow the symmetrical expansion of the stent. So will that matter in terms of his prognosis and the chances of the stent-related issues, restenosis or thrombosis? So these are my thoughts, and I think if we can discuss a little bit about how would all of us approach in these kind of scenarios, because anybody can have these kind of scenarios in their hospitals, and so would request all the Dr. Ramesh and Dr. Sreenivas to comment about it. Thank you very much.
Thank you, Dr. Rahul, for showing an excellent case and very relevant to today's discussion. And as told, first I wanted to mention that this is what the interventional cardiology beauty of it. Many times we would say that a critical left main RC occluded patient needs bypass surgery. In acute setting, it is different from the chronic setting. By the time patient is mobilized for surgery in a shock type situation, would worsen, and none of the surgeons would be also comfortable taking care of such patients in acute phases. That's how the stents have made this possible for us. And the lesion bed preparation with NC balloons, probably now more sort of other type of balloons have also come, IVL and things like that, for better bed preparation, who may not have had that distorted stent appearance. But probably in emergency, we can't. What you did is great. And because final lumen achieved is good with not much of malapposition, and patient should be doing fine and follow. Regarding to your other question of whether to put this patient on oral anticoagulation, not luckily his rhythm now came back to sinus, so there's no problem. In case if at all if it have required, probably we would use Novak and clopidogrel. Now this Onyx. I was actually surprised that many of the patients were just okay even with aspirin, stopping the P2Y2 inhibitors. I think we'll have more discussion after a few comments from Dr. Ramesh, and we can have again further discussions in the end. Ramesh, would you like
Yes.
to say a few words on this?
I just want to add that this atrial fibrillation appears to be secondary immediately after the surgery. So I would actually wait and put either a loop recorder or maybe the event monitoring, and then assess whether he needs long-term anticoagulation. But otherwise, everything else you have done, Dr. Rahul, it's very perfect. It's really amazing that you did this job. Excellent.
The other advantage of resolute stent is basically whenever you have such lesions where the proximal LAD is of less size and left main is of bigger size, doing part, the stents won't get distorted. The earlier version of stents, they used to get distorted, and the problem distally they would become narrow when you are expanding proximally. But this Onyx type of designs, which are much better, so it gives us comfort of doing the procedure also. And the OCT imaging will also help us to decide how to tackle this patient better. Congratulations, Rahul, for saving this patient. Now we'll go on to the second presentation. Again, I think Dr. Saidur Rahman Khan from Bangladesh. Thank you, sir, for accepting to present. And we'll take more questions, Dr. Rahul, in the end again. Then we'll have another interesting case of complicated PCI in HBR patients from Bangladesh. He's professor and cath lab director in Bangladesh. The beauty of that place is a lot of good work is done because most of it is pulled up in a few big centers. Unlike in India, where each of us do some work, there a lot of cases get referred to one place, and that's how each center is able to do high volumes of work, though country-wise it is small. Congratulations and thanks for joining, Dr. Saidur Rahman. Over to you for your presentation.
Yeah, thanks, Dr. Sreenivas. Actually, we have met you last in USA, and actually, you can see that gloomy picture because I have gloomy and exhausted greetings from this part of the world to you and to you also, because we are in the peak of the pandemic and the surprisingly and very we can say that almost 52 senior physicians already lost
Next
their
mirror
lives.
presentation.
So I'm really in a very here, but this is the case presentation and the academic discussions.
I can't get up.
Feel relieved a little bit from that sort of exhaustion. I'm in the hospital, so I'm covering myself to tell about a case which is not that much complicated like Dr. Rahul's, but it's a 76-year-old gentleman presented with angina class 3 to 4.
Dr. Rahman, could you increase your volume?
Yeah, it's
we are not able to hear you quite well. Could you increase the volume or maybe speak loudly?
So you can be closer to the mic, Dr. Sadhu.
Okay, I'll take the. I'm taking the microphone in that case.
Okay.
Now you can you hear now?
Yeah, better.
That's much better.
Is it clear?
Better, definitely better.
Okay. Okay, really, I'm very much exhausted. I'm in the hospital now. Yes. Okay, thank you for just for interruptions. This case is a 76-year-old gentleman presented with angina class 3 to 4 with recent non-HTMI. Actually, he has been admitted in different hospitals 5 days back with non-HTMI, and he has underwent the angiography there just 1 day back. And this case I'm presenting actually because I have done it in the lockdown period and in this extraordinary situations in this country and in our hospital also. And this patient is diabetic, hypertensive, and he suffered an ischemic stroke 1 year back, and with no residual neurological deficit here. He is a known case of moderate CKD with EGFR around 45. He is anemic with hemoglobin percentage is 10.3. So obviously the Bark criterion according to is obviously a case of HBR, and presently his ejection fraction is 45 to 50%. He had a history of doing the angiography 10 months back, again with the complaints of angina. At that time, the CAG revealed the totally occluded LAD, the CTO LAD with good retrograde collaterals from RCA, and recommended for PCI to LAD. But patient party at that time, considering the age, just continued optimal medications rather than engaging the coronaries. I think you're hearing me?
Yeah, you can.
Okay, thank you. Thank you. Then the present situation is that this time the angiography reveals that the same will collateral SCTLD. JCT score doesn't look that much higher, but along with the newer things that he has also severely diseased LCX and also a significant discrete lesion in PLV branch in its mid part. This time he actually had no choice to overlook. In these extraordinary period situations in all the hospitals here, we just deshouldering. We wanted to deshoulder the patient for the surgeons, but the surgeons left the scene as quick as it can, seeing the comorbidities. So this is the angiography. You can appreciate that the good retrograde flow from RCA, and also the LAD you can see here. So what to do? Apparently, it didn't seem that much harder, and then geography didn't seem like that the 76-year-old coroner is there. Though you know that in case of elderly patients, the coronaries are very much deceptive. That the hidden calcium, loss of elasticity.
Anand, were you able to see the slide of angio? Because I am seeing sir, but I couldn't see the angio.
You didn't see the angiogram based on angiography?
No, I was able to see, Dr.
Okay. Go ahead then. It's okay.
Isn't it? Have you seen
Yeah.
it, Dr. Sreenivas? Okay.
No, we were able to see your angiography.
Okay.
You are able to see? Okay. Okay. And this is the angiography. Srinivas, are you seeing that one? Now you're seeing that one?
I'm seeing sir's picture is big. I'm not able to see the screen.
So we can see you, Dr. Sreenivas. You have to exit the full screen view, and then
Yeah.
you can
Yeah.
see.
Yeah. Okay.
Dr. Rahman, we can.
I'm able to see now.
Okay. Thank you. So this is the angiography, because this angiography has been done just in a different hospital, one just a day before coming to my hospital. So what to do? Apparently, it didn't seem to be hard one to treat that situation, because only the gray zone was the proximal cap in elderly patients, which is very fishy sometimes. Antegrade approach is the preferred one, though interventional collaterals or retrograde approach is also very lucrative. Distal to CTO segment, if you see, if you see the LED from the RCA, the distal LED has got a long segment diffusity, so you need a longer metal jacket if we can cross the sedulation. And considering age and comorbidities, and as a case of HDR, the DAPT duration is a very big issue, and we should choose a scaffold of better, preferred, justifiable, and considered quality, no doubt about it. So what we planned as a radialist, the vascular assist should be radial, to be radial, and of course, obviously good for this elderly patient too. And biradial access should be ensured so that the blind wearing to nowhere is prevented. Guidewire selection, of course, is the operation, and for me is the Gaia or sometimes I start with the plain hydrophilic one. And being a bit slender, I usually, my almost 70% PCIs, I usually prefer the 5-French catheters. And for this patient, it was very important because this radial diameter was too small and calcified to accommodate the 6-French. And for 5-French catheter, it's not a big problem for me for the active support, because we can make alpha or gamma looping for left section. And macro catheter is in my shell, but I have always some newer ways to treat the several hundreds of CT pages. Not all the time I use microcatheter. So I took the 5-French gel 3.5 gauge catheter and a PT2 in intermediate support Boston hydrophilic guide wire. So the guide wire is there, and now you can see that is the smallest balloon here, 1.25 into 5 millimeter. And this gives very good support for the wire to just steer the wire. I've kept the balloon just distal to the tip of the just proximal to the CTO segment. And then the wire is crossing much trouble to me. And it has been also ensured by the dual injection here that the wire is in the right track, which is very much important for the elderly patients, because sometimes you may experience that it's down to the totally into the submental space easily. And with this balloon support, then you can see that it is truly hard enough to just cross the 1.25 into 5 millimeter balloon in the CTO segment. I'm pushing hard, but it's not going. Then in the second picture, you can see that I have made that looping, which is called the gamma loop, with holding the balloon and the wire. So you can 5-French catheter easily you can make that loop, which will give you very good support. And then after that support, the pre-dilatation was done with the same balloon. And I have got I have been able to see the upgrading with a 2 into 5 millimeter, 2 into 15 millimeter pre-dilatation balloon there. And then it was very good to see. Very easy to. So then it was a piece of cake, a 2.5 into 30 millimeter disc. Especially I have taken the onyx distally, and then 2.75 into 22 millimeter disc proximally overlapping each other. And enough post dilatation by the 3 into 15 millimeter and up to 24. And then the LCX with the same wire. I didn't want to change that hydrophilic wire either. And then direct stanting was done in 2.5 in 36 millimeter days. Addition, which is very important for elderly patients to approach the stent very properly. And a picture. So it looks like a young coronary in the long run. So not a bad result. Considering this, let's say CKD status, less contact use were pre-planned and subconsciously it has been implemented. Not too much wasting of time in the cath lab in corona era. Stent was chosen considering the case as HBR, and as we have curtailed the duration of DAPT so far after Onyx Clear One study. Obviously, fortune favored us. The CTO did not give too much trouble. So for any case, actually, it is very much difficult and confusing because every case is different. And so nothing I can tell as a take-home message for this. Especially for older patients with complex coronary anatomy, meticulous planning is necessary. Trial-based stent selection is to optimize the safety and efficacy is also a dire necessity, especially now in our elderly subset of patients are increasing. For HBR cases, we have limited RCTs considering the duration of DPT. It's really still pretty unclear. Some trials, especially dedicated for these HBR patients like Liver-Free, Senior, Juice HBR, and the latest one is the Onyx Global and Clear. So these trials are giving us a little bit courage to just curtail the DAPT durations. And also the stent selection, the scaffold selection is also very much important nowadays because these are a very elderly HBR cases. So here, according to drug, polymer, and platform, we have to choose the stents, no doubt about it. This is really important sometimes. And for HBR cases, procedural success is not enough. Optimization of DAPT is a huge concern, which I have told again. And for these patients, I have just planned to give 1 month DAPT followed by SAPT. But you know that it's an SES setting, so whether it will be appropriate or not, time will say. Thanks for patience hearing. I finished the case, Sreenivas. Have you heard it? Hello.
We could hear you, Dr. Raman's presentation, and while I wait for Dr. Sreenivas to join, I think this is really a very well performed CTO. You know, obviously you're an expert in that, and you're able to show how overlapping stents and using resolute Onyx would at least shorten the DAPT in patients. Really, very nicely done. Dr. Sreenivas?
Yeah, congratulations, doctor, for showing another excellent case. And as very pertinent to our topic of discussion today, this elderly gentleman had a major bleeding criteria. His hemoglobin was less 9 grams, and he had multiple CKD and other parameters. The earlier case presented was a major surgical case, and now this is another criteria of high bleeding risk, which have shown multiple problems. As shown after the inventing radial procedures, I think one of the other half of the problems of high bleeding risk, whatever bleeding problems which are happening to access site are gone. And even in CTOs, yeah, it's good that you're doing a radial procedure. And there was a faint track, I think that's how the fielder XT wire could cross. Even otherwise, sometimes fielder XT helps. Many of the times, microchannels are there in CTO, it was told. And finally, you got a good result. And that's how the encouraging radial procedures more also goes a long way in preventing the bleeding complications in these patients. And as you said, also matters, and the stents are giving us the power to avoid surgery many times. That's how I keep saying, instead of surgical standby, now you do procedures with stent by because of the good quality stents. which are easily trackable. Many times I had seen the onyx stent. Sometimes a complaint, NC balloons won't cross, but a stent will cross. But it's not to expand and put the stent directly unless the bed is prepared well. But that sort of low profile stents being there is always good to tackle such patients. I think we'll have a little more discussion from all the panelists in the end of the case because we will go on to the next presentation. We will have, is Dr. Sarita joined now? Coronary calcium, the three musketeers. It will be presented by Dr. Sarita Rao. She's interventional cardiologist in Apollo Hospital Indore. Even India is rising. The tier 2 cities, 3 cities in the country also are doing significantly good work. Indore has become another major center of. Actually, it's supposed to be popular for business in the country, but even all the procedures, high risk procedures, and recently they have done. I was told that they did one Tower 2 with the corporate Medtronic. And then when her husband also joins him, he also interventional cardiologist there, and she has a lot of gold medals, Padma Bhushan awards to her credit. Unlike many other female interventional cardiologists, I won't share this. She is dynamic and does a lot of excellent work. And many of the times they both are stuck in cath lab. So that's how she could. She finally, thank you, madam, for joining us. And we would like to hear more from you on this coronary calcium, the three musketeers. The case, over to you, Dr. Sarita.
Thank you, Dr. Sreenivas.
Yeah.
So I hope I'm audible to everybody.
Yeah. We can see you and we can see your slides too. Go ahead.
Okay, so thank you, Dr. Sreenivas, and good evening, ladies and gentlemen. And I will be talking about calcified coronaries. So fibrocalcific plaques, they've been known to reduce the vessel distensibility and impair uniform balloon dilatation and subsequent stent expansion, as we know, and various technologies have been developed for this. Rotational atherectomy has long been considered an adequate choice for plaque preparation, dealing with highly calcific lesions even after balloon failure. However, in larger vessels and in lesions that are not so tight, the birds might not be able to ablate the plaque. And if at all, it only modifies the intimal calcification and doesn't really deal with the circumferential calcification. So I will discuss in short a case-based presentations with three of the most successful devices in our armory to deal with these calcified lesions, two of which are relatively newer kids on the block. So there are various challenges of treating calcified coronary lesions, and we are aware as the calcification goes up, so does the results. So in my first case, nothing seemed to be right over here. This is a patient who had an anomalous left main coronary artery arising from the right coronary sinus and had a calcified left vein lesion which had been attempted in another city about a month ago and it had failed. This was before the ideal days.
Are you hungry?
Backup was the real issue. So we took a buddy balloon and a buddy wire in this circumflex. A 2 into 10 millimeter balloon at high pressure didn't succeed in dilating the lesion. A 2.5 non-compliant balloon failed to cross, so 2 passes of a 1.5 burr of a rota was done. Post-rota, a 2.5 balloon crossed, but the lesion did not yield with even 20 millimeters of mercury pressure. So the stent finally, however, could go through because of the rota. And after dilatation with the 2.5, there was dog boning suggestive of circumferential calcium. Subsequently, later OPNNC was negotiated and it was inflated. And the stent was finally dilated with 38 atmospheres of pressure. This was the final result of the patient. So, with the OPNNC, it's most important to avoid polymer sleeved wires. So, distal lesion use extra support wires. For pre-dilatation of 0.5 millimeter lesser size balloon, and for post-dilatation of 1:1 ratio has to be used. And the pressure needs to be increased gradually after 20 atmospheres, leads to uniform dilatation, avoids unnecessary overinflation. And it's a very useful tool now because it has a twin layer construction with virtually zero dog boning effect. So my learning point in this case was that the buddy balloon helped me in stabilizing the guide, rota helped me to deliver the stent, and OPNNC did the trick of final expansion. Using it inside the stent, it acted like a high-pressure cutting balloon with which we could yield the circumferential calcium. In my second case, there was companion embolization, which is the forgotten masked menace. This is a 51-year-old male, diabetic and hypertensive since the last 5 years. He had an angioplasty to the right coronary artery about 4 years ago at another center in another city. His symptoms recurred. His ejection fraction was about 30%. His angiography revealed a circumflex osteoproximal 90% long segment disease. His LAD was calcified 80%, and his RCA showed a CTO in stent restenosis. With all of these, he was advised, I think my screen suddenly disappeared.
Ma'am, you can again go to your PowerPoint.
How do I go to it again?
So on the bottom, you will see a PowerPoint presentation logo. You just need to click that and you will be directly to your presentation. On the bottom of your screen.
Okay. So it's back. Can everyone hear me?
Yes.
Okay. So the angiogram revealed a circumflex osteoproximal 90% long segment disease. LAD was a calcified 80% lesion. RCA was a CTO, in-stent restenosis. With all of these, he was advised for a bypass surgery, but he denied the same. So this was his RCA, a CTO. Circumflex, 90% osteoproximal long segment of disease. LAD, calcified lesion, 80%. The circumflex disease was particularly bad. So we went ahead with the rota. This was a 1.5 burr in the LAD, and we were able to cross it. This was post-rota. You can see the flow. Then the stent was implanted in the LAD. And this was the LAD result. Subsequently, we took a 1.25 burr and we entered the circumflex. And this is what happened. Post-rota, there was no flow in the circumflex and there was haziness at the LAD ostium. And this was immediately followed by no flow in the circumflex and the LAD, followed by a cardiac arrest. Patient was revived, shifted out with tirofiban on board on a TPI, a ventilator, after re-establishing good flow in the coronaries. Now, what happened at this point? So the reason was, we know that slow flow, no reflow results from microvascular embolization of atherosclerotic debris in thrombi, platelet activation, vasoactive mediators, and is associated with a peri-procedural MI. It has also been hypothesized that microcavitations created by the rotating rota ablation burr across the lesion also contribute to slow flow or no reflow. This transient microcavitation phenomena directly correlates with the rota ablation speed, the burr size, and the duration. Incidence of this complication is generally about 2.5 to 5% in various contemporary reports, and factors which contribute to it would be larger burrs, longer runs, sudden decelerations. So as soon as this burr was removed, there was embolization in the LAD from the shoulder of the burr, which caused slow flow in both the vessels, leading to this catastrophe. We managed it with distal bed perfusion with vasodilator and tirofiban, given through a microcatheter, which was the cornerstone of the treatment here. Next day, we took this patient for an angioplasty again to the circumflex and the RCA CTO. The next day was uneventful. Patient was extubated on the same day. This is the circumflex stent being placed. The post-dilatation. This is the final result. RCA, in-stent restenosis CTO. It was crossed, ballooning, and stent deployed without any further issues. So in our case, LAD was the side branch as it was the ostial circumflex with a very short left main. Since the secondary protective wire could not be used with the rota ablation system, so careful attention needs to be given. In most of the cases, it is due to microparticle debris or vasospasm, in contrast to the usual angioplasty, in which it is due to plaque shift. To prevent occlusion, the burr could be platformed distal to the takeoff of side branch if possible. But in a pullback, there are chances of companion or side branch embolization, leading to the sudden arrest which happened in our cases. So slow flow, no reflow is common during rota, but retrograde embolization of the companion artery is relatively low. And it is one of the most challenging adverse sequelae observed in under 5%. So excessive plaque burden, long lesion, a long ablation time, vasospasm, platelet activation, microparticulate aggregation, all of these would increase the chances of it. How do we prevent it? Deploy the burr in a stepwise method to minimize effective plaque burden. Limit the ablation time 15 to 30 seconds, gentle advancement, intermittent retraction, slower speed, lower platelet aggregation, so beneficial in prior use of GP2B3A. Osteal lesions usually should be avoided, or we use a smaller size burrs for a very shorter time. Now, so we've always had good experiences with rota and some bad experiences like this one. However, the outcome was good. But every time we used rota, we always wished that we had something simpler. So thankfully, we got intravascular lithotripsy on the board shortly after this previous case. Now this was, and we had very good experience with IVL, and the patient, there was complication rate was very low and the patients responded very well. So then we got very ambitious. Now this is a patient who was a 67-year-old male, inferior wall MI, 45% ejection fraction, recurrent angina, lately unstable. His angiography revealed triple vessel disease with huge chunk of calcium in all the arteries, and he was categorically denied a bypass surgery. So this was his angiogram. You can see codominant circumflex, proximal 80% eccentric lesion, heavily calcified LAD with mid-distal 80-90% calcified stenosis in the LAD. In this, you can see the amount of calcium along the entire course of the LAD and the stenosis. Couple of views just to show the LAD and the codominant RCA, which was a CTO. So we went ahead with the 2 into 10 millimeter balloon, negotiated across the LAD lesion, and we're trying to dilate it. Undilated balloon, there was dog boning of the balloon. Subsequently, distal lesion was also crossed. Repeat dilatations. Now we took the IVL balloon. Now with the IVL balloon, we had a partial dilatation and that the balloon ruptured. So now we have a problem at hand. We needed a second balloon, and that too, in our setups, it has to be paid for by the patient, so it's very costly. And thankfully, the company people provided us one more IVL balloon. The IVL balloon successfully dilated the second IVL pulse. Post IVL, we had an adequate bed prepared for the stent delivery. The distal lesion again was redilated. However, now when we tried to implant the stent, it would not negotiate around the bend. As you can notice, this playing of the wires on pushing. We tried all the usual tricks which we try, double wires, balloons, additional balloons, extra stiff wires, everything was tried, but the stent would not negotiate. So ultimately, then again, we dilated with 2.515 NC balloon at the bend. Still the stent did not cross, so ultimately we had to take a guide liner to deliver the stent. Mid part of the stent was still indented, and this is just to show the amount of calcium which was there in the coronaries. The undilated portion, this is the circumflex lesion, which was also very calcific and was dent with OPNNC post the IVL therapy. The second stent was deployed with ease. Post dilated with an OPNNC 3 into 15, and this was the final result. So too much of calcium is very tough to crack. And although IVL has simplified the process, so has an OP and NC, which are now the most physician-friendly tools at this time. Rota, however, still finds a place where the IVL balloon cannot be crossed. IVL, OP and NC are two newer innovations to complement our age-old but risky and tricky rota to work in tandem to tackle the calcium, which is the Achilles heel of PDCA. These three cases demonstrate that different subsets of patients may require any one or a combination of all the three musketeers to tackle the tough calcified lesions in the coronaries. So ladies and gentlemen, thank you so much.
Thank you, madam, for showing excellent cases, all calcific lesions. No wonder surgeons get worried. Now we do TAVR, we do calcific left mains, and even instant restenosis after RCA. Still, we have problem. All tackled continuously. No wonder our surgical colleagues are getting. Recently, in one of the meetings, even the top surgeons were getting agitated when I presented some TAVR cases. So no wonder, because of a good technology and technique available, increased experience, we are able to do justice as we show. But bed expansion, immediate proper result is very important when you're tackling such high risk pathologies, because underexpansion could lead to trouble. I think these high pressure balloon inflations and all that help us to do good results to the patients. If they, as we all should remember, if immediately results are good, then the patient will also have long term results, which will be good. And not to have immediate hospital problems also is important. Congratulations for showing good cases. If any comments, Ramesh? Then we'll go on to the next case.
I think excellent. I mean, this is really a conundrum of coronary calcium and how it could be tackled by the different devices that are available to us. And Dr. Rao here has shown with a great vast experience how to really do a good job in making sure the stents are well opposed. And we can't blame the stents for failure of the stents if they are not well opposed and post dilated. And here, I think that's really very good to see all the use of all the balloons that to post dilate.
I think as both of them, both husband wife being at the cath lab same time, then you not worry about home. So both of them keep working very long and give good results to patient. Congratulations to both of you, madam. Then we'll go on to the next presentation. We'll have some discussion in the end again, madam. We'll have now next presentation from high risk PTCI. This is another subset of HBR patients where he requires oral anticoagulation. This patient had a complex cardiac history, had need necessity for oral anticoagulation, and how PCI was done with using what stent. We'll hear it from Dr. Pandula. He is from Sri Lanka. It was very particular that we should have somebody from this place, and Medtronic made this possible. And can we project his slide? Okay. And then I spoke with him, immediately agreed, and we'll hear more from him. Dr. Pandula, please.
Okay. Dr. Srinivasan and Dr. And the elite panel here, thank you very much for inviting me and giving me the opportunity to present in this forum. I hope you can see my desktop.
Yeah, we can see you.
Thank you very much. So I want to present a few of our cases with HBR patients who required PCI with drug-eluting stents in the past few months to share the experience and then discuss the kind of problems that we encounter when dealing with such patients. My name is Pandula Tavadarachi and I work at Denton's Heart Center, Colombo. Okay, so move on to the next one. Okay, I don't have any conflict of interest. The first patient I want to present to you is a patient who needed mandatory anticoagulation, who needed urgent PCI. This lady was a 69-year-old lady, non-diabetic, very small built, a typical Asian lady, 4 feet 11 inches tall and weighing only 42 kilograms. That itself is a substantial risk factor for bleeding. She had previous triple vessel coronary disease, severe aortic stenosis, and mitral regurgitation. And she underwent a CABG with 3 grafts to LAD, OM, and RCA, and mechanical prosthetic AVR and MVR in 2014. And this AVR was placed with widening of the root because the smallest available mechanical prosthesis still could not, be incorporated into the aortic root at the time of surgery. So hence, there was no choice. The patient had to be on warfarin. And patient had preserved LV systolic function after the surgery and was kept on warfarin and clopidogrel since 2014 with a target INR around 2.5 to 3.5. She was kyphotic. She developed idiopathic Parkinson's disease and had reduced mobility. And she had family in UAE, and she's been traveling back and forth from Sri Lanka and been staying with the daughter in UAE. So this is the background. And on the top of this background, she developed recurrent shortness of breath, followed by chest pain, followed by a collapse in UAE. And this happened in 2017, July. She had new onset left bundle branch block and raised troponins during that hospital admission. Because of the situation with the warfarin, they initially decided to do a CT in UAE. Unfortunately, because of the artifacts and the filling, they could not be sure whether the grafts were functional or not. However, they saw some flow in the native LAD. Coronary angiogram done in UAE subsequently with INR of 1.8 resulted in a large hematoma in the groin. Unfortunately, they could not even proceed to find whether the Lima graft was patent or not during this admission. For whatever reason, we are not entirely sure. In the end, with the hematoma, being compressed, medically managed, the patient was shifted back to Sri Lanka in about a week's time, where I came into her care. We found that patient had intermittent chest pain, shortness of breath with shifting of the ST segments, even with slight mobilization. There was dyskinesia of the anterior wall on echocardiography with left bundle branch block persistent. She was also known to have hyperglycemia, which sounded like she had newly diagnosed diabetes mellitus based on the blood tests. The large hematoma, fortunately, after compression, did resolve, but did not give rise to a pseudoaneurysm. But her hemoglobin stayed low at 10.1. So with that, we took her to the cath lab and then had a look at her coronary arteries. I hope you can see my images here. You could see that the ostial left main, ostial LAD still has the original significant lesion that was there that led to the bypass in the first place. Circumflex, although has a proximal lesion, has been bypassed with a functional graft, and there is collateral flow into the distal RCA via the circumflex territory. The graft to the right was patent, but it was a miserable looking graft, as you can see on the right hand side there. The graft to the circumflex artery gave a good flow to the circumflex territory, but it was not supplying much to the LAD territory. And you can see the Lima graft, surprisingly, within 2 years, had completely become atrophic and had absolutely no significant flow whatsoever into the LAD territory. So that was not surprising that she was developing anterior ischemia. So here we are, the two lesions in the ostial LAD segment in particular, plus angulated lesion in the mid LAD, which probably was the site of the Lima anastomosis, which seem to be the two culprits that we need to tackle here. So what do we do here? The clear-cut case of HBR case and the case concerns were that we needed to continue on with warfarin as a must, and we had to use the shortest possible course of triple therapy in this case, use minimal amount of heparin in order to not to aggravate the compressed hematoma on the ipsilateral side, or the contralateral side, of the current puncture. And then with the history of new diabetes and left main stem disease, we had to use the best available choice of stents at that particular time. And then also the deliverability across angulated mid-LAD lesion had to be taken into consideration. So if you look at the ARC HBR criteria, she had at least 3 major criteria for high risk, plus 1 minor criteria. So there was a no-brainer that she had to have a stent with shorter duration of antiplatelets to be implanted at this stage. In 2017, we did not have access to Onyx, but we did have access to Biofreedom. We chose this. I was a little bit concerned with the thought that this was a partial bare metal stent, which would be placed in the ostium of the left main with a history of diabetes. However, the choice was decided by the fact that patient need a shorter DAPT. So here we are, the procedure was done, and we had a good result in the ostium of the left main and the LAD plus the mid LAD, and had a good flow with resolution of symptoms and ECG changes. Post procedure, we managed to get away with no acute or late bleeding events in the first month. After the first month, we adopted the strategy of clopidogrel and warfarin alone, and there was no drop in the hemoglobin after 1 month. Patient had subsequently, though, a fall after 9 months and had an encysted bleed into the pleural space, which was subsequently ultrasonically guided aspiration was performed, but we decided to continue only with warfarin thereafter. She did well, for 3 years with no further cardiac events on warfarin alone. But unfortunately, she had succumbed to a non-cardiac illness during the current corona epidemic, and with a viral gastroenteritis and severe hyponatremia in UAE recently. So this illustrates, one of the common reasons, I like to use a quicker healing DAPT and a shorter DAPT regimen in a patient like this, who has a lot of risk of bleeding. Okay, so my second case deals with a patient with a high bleeding risk requiring primary PCI during the corona lockdown. This is a real case, from the last 2 months. 55-year-old gentleman with diabetes, had end-stage cirrhosis, and previously had banding for varices and had gastropathy and a hepatoma that was resected. Hepatoma arose because of the end-stage cirrhosis, and patient had undergone liver transplantation in January 2020 in India, just before the COVID epidemic started. Patient had been immunosuppressed and was on MMF, tacrolimus, and steroids. Unfortunately, post the transplantation, had a reactivation of pulmonary TB, which was dormant previously. And he had been on treatment but missed doses during the corona lockdown, and therefore was partially on treatment. Patient presented to my unit with chest pain, shortness of breath, seen as an emergency despite the risks to the healthcare workers and all the staff in my unit. We saw that the patient had acute anterolateral STEMI with impending shock, with a blood pressure of 95, with ongoing chest pain. The coronary angiogram was done in January 2020 prior to the transplantation, and surprisingly, this showed no significant coronary disease. But however, once we took the patient to the cath lab, it was quite obvious what has happened here. The proximal left anterior descending artery had completely occluded with thrombus. So here we are, faced with an immunocompromised patient coming during the corona outbreak, with no background story about the current HB status and bleeding risk. And we had a situation where we had a diabetic patient who needed proximal LAD PCI with the lowest possible dose of heparin, and the requirement for a rapid healing DES was paramount in this situation. So we crossed this LAD. Fortunately, it was easy to cross and open up the vessel. This is a Onyx 3x30 drug-eluting stent inflated with single inflation followed by single post dilatation, which opened up the artery with TIMI3 flow restoration and resolution of the ECG and the cardiogenic shock state. Patient, however, continued to have low platelet counts with splenomegaly resulting from his previous liver disease. However, we managed to get away with no hemoptysis or GI bleeding peri-infarct. We decided to go ahead with levels monitored with of tacrolimus only as an immunosuppressing agent. Doses were adjusted, and then we restarted the anti-TB drugs. And we have continued with the DAPT regimen more than 1 month now with no ill effects, and we are hoping to curtail the regimen if bleeding were to occur. Now 2 months have elapsed. My plan strategy would be at 3 months we will make a decision whether single antiplatelet therapy alone would be sufficient, subject to his lab results. So moving on from the HBR case, we wanted to discuss, how deliverable stents, actually help us tackle on complex cases. The third case is a case of how to solve a surgical case like Maria with PCI instead of CABG. So it's a 65-year-old male, non-diabetic, ex-smoker, presented with exertional breathlessness, and then subsequently presented to us with a non-ST elevation MI. However, had good LV systolic function. He was a chief architect of a large enterprise and was very unkeen to undergo extended period of invalidity. He had a previous history of GORD with hospitalization for that particular incident, but no active symptoms at present. Coronary angiogram showed triple vessel coronary disease with a very high syntax score of 47, but despite repeated consultations by myself and the cardiac surgeon and the heart team suggestions, refuses to budge under any circumstances to go for CABG. I'll show you why his coronary anatomy is such a explosion here. You can see the left main, distal left, tapering of the left main with double angulation into the circumflex, double angulation into the LAD with calcification, with 111 Medina true bifurcation lesion in the distal left main stem. Right was even horrible than this. You could see in the RAO cranial projection on the right hand side, there is quite an ambiguity of the origins of the channels through the what looks like a recanalized CTO. And despite discussing this extensively, he still wants to have undergo PCI. So what do we do? And how did I approach it? Here's my strategy. I felt that it was mandatory to do the right coronary artery first to get better support for the complex PCI required in the left, so that I get hemodynamic support from the right, before I engage the left situation. We wired the right coronary artery carefully with initially a field wire into the right artery marginal branch, then used a Gaia second wire, stiffer wire, through the number of occlusions into the distal RCA. This gave us enough of a rail to get a small Ikazuchi balloon across the angulated segment and then achieve a good predilatation, followed by a very easy progression of Onyx 3 by 38 millimeter drug-eluting stent. And surprisingly, this is the nice final result in the RCA that we see here after the PCI. Then we went on to tackle the left main with a Q-lot stenting of the distal left main into the LAD and the circumflex. Wired both the lesions, had a lot of pushing and pulling to get the equipment into the right place. Initially stented the circ and the LAD, and then we did a simultaneous kissing balloon inflation, followed by proximal optimization up to 4.5 millimeters with a pod balloon. And this is the final result that we have achieved with good flow in both limbs and satisfactory final angiographic result here. Patient has been followed up to about 2 years now, and he has had no complications. He had excellent effort tolerance and complete physical activity, and able to complete a full 12-minute full Bruce treadmill testing at the end of 2 years. We had a curtailed DAPT regimen despite the anatomical complexity. This illustrates to us that having good quality stents that we can trust to deliver treatment for HBR patients as well as complex coronary anatomies will be useful. And it is likely to be the norm than the exception in South Asia for a time to come in the future. The strategies for diabetics, left mains, and primary PCI with no immediate access to lab results will all be a normal routine for all of us. And we might need to deal with calcific coronaries, smaller BMIs, and sometimes in some parts, dengue hemorrhagic fever threat. And this calls for shorter DAPT with increasing PCI complexity at the same time. So thank you very much. And I would be more than happy to discuss any of the 3 cases that we presented today.
Actually, Dr. Pandala, congratulations for showing excellent cases. Only the problem is we are running short of time. You have shown very good cases. First one, probably when the patient had hematoma on one side, probably would have preferred doing radial procedure if possible. That also showed probably ostium of LAD when it was bypassed. If that ostium of LAD is not very critical, the Lehman's tends to get occluded more faster. That could be one of the reasons for getting into trouble in that patient.
Correct.
And second patient, probably in corona time, she came positive with corona, or she was negative for that?
Unfortunately, she was in quarantine when she did this. She was in the isolation ward, and then apparently in UAE, they took 3 days to get the corona test. During this time, she had already had hyponatremia.
Okay.
So subsequently, the test came back as negative, but she had a different issue due to the electrolytes afterwards.
Yeah. God has decided to win because you are not allowing, in spite of all odds, to this thing. Then that's how it is happening. Anyway, congratulations for an excellent work, and that's how all the profession needs to be commended. In spite of tough corona times, risking our lives and families, we try to treat patients, and these DAPT regimes. And there is some data coming up that in corona time there could be little more increased stent thrombosis rates also noted because of more of coagulation patterns. We need to be a little careful about it.
Correct.
The last is the result before and after. After his result is so good with better quality stents, it looks like why to send for surgery in such cases. So that's the beauty of interventional cardiology and stents, and that's how patients do well. Especially young patient like that, I think we can avoid the surgery. But other thing, what you showed is the most toughest and the sequel lesion to be opened first. In case it fails, then probably patient could go for surgery. And the result was good, and that's how you tackle the other two vessels.
Indeed.
I think congratulations for good work you're doing, and take care. Ramesh, you want to like to say anything? Otherwise, we'll go to the last case because we're running behind the schedule. And Dr. Ramesh also needs to show some data about the next stent. Ramesh?
We can go to the last case, and
Yeah.
it's really excellent presentation, Dr. Padula.
Thank you.
The cases are so good, we tend to want to discuss more and more, but because we also need to adhere to timing. The other last case will be by left main complex case presentation by Dr. Chandramani Adhikari. It is he's from Nepal. Again, Nepal, though it is on the top of India and it was lagging behind before. Now, with the advent of National Academy of Medical Sciences, other hospitals coming up, I think Dr. Chandramani was initially trained in China, but being native of Nepal, he came back to serve his motherland and is doing good work there. And over to you, Dr. Chandra, to see your case of left-main introduction.
Am I but audible?
Yeah, clearly audible. Go ahead.
Okay, thank you, Dr. Sreenivas, for giving me this opportunity. So my presentation will be too short. I'll be presenting few cases, 3 cases. So these are all left-main intervention which I have done few years ago. So we all know that the left-main stenosis is the highest risk lesion subset of coronary disease, and in its incidence is between 5 to 7% in coronary angiogram, and majority of them involves the distal bifurcation. We all know that traditionally CABG is the preferred treatment option for left-main disease, but PCI of the left-main stenosis has been rapidly expanded. In isolated left-main lesions involving the ostium or the shaft, PCI is easy to plan and perform. The problem is distal left-main bifurcation lesion is a good planning at it is a bifurcal lesion, and we all know that for all the bifurcating lesion, provisional stenting is the preferred approach as it is technically simple with at least similar outcomes to a systemic two-stent strategy. So I am going to present 2 cases, one with a single stent strategy and another one with the double stent strategy. So first is always when we plan for a distal left-main bifurcation lesion, we always plan for keep it simple. So this is a case of a 70 years old male. He had a chest pain on exertion. He is hypertensive. He was offered for CABG because of the left-main disease, osteal left-main disease, but patient and his son refused for CABG. So this is the right, and on the right hand side, this is the left. You can see a tight lesion on the ostial left pain. So what we planned, because he's 71 years, so we planned it in a easier way, and there was no lesion on the ostium of the LCX. So what we thought is we can come up with a single stent strategy. So he's a father of a doctor. So to make everything safe, we inserted a TPI, and LED and LCX was wired with the BMW and Sion blue wire, pre-dilated with the 3x12 NC Trek balloon. Then what we did is we put the Resolute Integrity 4x30 stent, and then flared it up by putting the same balloon of the stent in the aorta, and then again completed with the pot doing with a 4.5x12 sapphire balloon. So this was the final result. You can see that I think the result is quite good. So we achieved TME 3 flow in both LED and LCX, and being 71 years, LCX is flowing good. What we decided is we can come out with a single stent strategy, and this is the final result. But what is there is we cannot keep everything simple. Sometimes what we have to do is we have to make it a little bit complex because of the nature of the lesion on left main LED and LCX. So this case is a referred case from CABG from some other hospital outside Kathmandu. He had a chest pain on exertion. His hypertensive. He was explained that the ideal situation is CABG in this case, but he refused. So this is the lesion. Right was perfectly normal, and the left, you can see that the ostium of the LED in the nostril of the left vein, as well as the LCX, proximal LCX, there was a tight lesion. So what we thought is we will go for the provisional stenting in this case. So what we did is we wired the LED and L6. Sorry, it's not moving.
You can go to next.
It's not moving. Sorry. I think there is a problem with the laptop. So I'll just explain. So what we did is we wired the both LED and L6, and we pre-dilated the lesion LED and L6. What we did is we put a stent from ostial left vein to the LED, and then what we did is we crossed the wire from a left vein to LCX, and what we did is we did a tap, and then my computer is not running. I cannot go forward. With this slide. Can I join later?
Doctor, you can just escape this, and you can just press the escape button and then make a full PowerPoint presentation.
No, I cannot do that. I am trying to do that, but it's not going. Can I just switch off once and then come back?
No, don't switch off.
In the meantime, you
don't switch off. Just click on stop sharing. Dr. Chandramani, just click on.
No, I cannot.
Okay, I think.
Okay, wait.
Now you can do it.
Yeah.
Hello.
Okay, Chandra, we can see it. You can go to the final picture.
So I think I was here.
Yeah.
So what we decided is which wired both, and we put a pre-dilated into 10 and 3.5 into 12 sapphire balloon. So what we put is a resolute integrity from ostial left vein to LED 4 into 38 at 10 atmosphere pressure. Then what we did is this is what we are doing, and then we cross the wire towards the LCX across the left vein to LED stand. Then put a resolute integrity of 4 into 18 in the LCX. Then we did a kissing balloon in LED with 5 into 18 at 8 atmosphere and L6 at 4 into 18 at 12 atmosphere, and we did a pot in the left main with 5 into 8 balloon. So this was our final result. LED and L6 are patent and a good end result. So this was the final result, and I'm going to share this case which I did few years back when I was not that much experienced. So what had happened is there was a 63 years old male. He was referred due to chest pain on exertion, single vessel disease. So we planned for PCI to the LED. It's a very short case. This was the lesion. There was a total occlusion from in the mid LED. So what we did is we crossed the lesion, we wired it, ballooned it, and then we put a stent. We put a 4 into 20 Promos stent, Then what had happened is suddenly we noticed that there is a dissection for left vein to LAD. I think you can see the dissection clearly. I thought that this is because of the guiding catheter itself. So what we did is we immediately put a wire in the LCX, then immediately took a 4x32 stent from Austin left vein to LAD, and that was the final result. So in conclusion, though single stent provisional approach is the preferred strategy in left vein, distal left vein PCI, but case-based approach is very important. Case selection, careful pre-procedure planning is very much important. Thank you. That was just a slight small case presentation. Thank you, Srinivas and Metronics team for letting me present me the case. Thank you.
Thank you, Dr. Chandra, for showing interesting cases. So in case of doubt, probably availability of imaging is also a problem. When there is a doubt of lesion significance, and probably pre and post assessment by imaging would help a lot, especially in dealing with such left main type of diseases. And probably, though drug-eluting stents lengths do not matter, but probably optimal sizing and length measurements also can be helped by imaging. I think we'll have a little more discussion because running slightly behind. The people are eager to listen to Dr. Ramesh also. We'll have his presentation, then we'll go for discussion. Thank you. Over to Dr. Ramesh. Can we have Anand? Can we have Dr. Ramesh slide?
I'm just transferring the presentation right. 1 minute. Yeah.
Thank you.
I think he has to unshare, no? Anand?
Dr. Sreenivas, can you hear me?
Yeah, I can hear you well, sir. I'm not able to see
thank
your
you.
slides, but
Yeah, so can you bring up the slides if you don't mind, Dr. Sreenivas?
Yeah, I have transferred the presentation rights to you, Dr. Ramesh.
No, to Dr. Sreenivas, I thought, but I can do it if you want me to do it.
okay, I'll do that. Okay, I'll get the slides. Transfer that to.
Shall I transfer this to you, Dr. Sreenivas?
Yeah.
Okay. Yeah, you're the presenter now.
Okay. Get you the slides 1 minute.
So thank you very much. I think excellent cases have been shown this morning, this evening for you all. I think it's really wonderful for Dr. Sreenivas to bring in such a conundrum of patients with some are post-surgical, some are already on anticoagulation, some of them are very high, complex, calcified lesions, and the post-surgical patient was shown by Dr. Rahul Gupta, and Dr. Sarita Rao has shown excellent complex scenarios and calcified lesions. And Colonel Wintow showed his excellent tumor patient, and both Dr. Pandura and Dr. Adhikari have shown great cases of complex left main lesions. And Dr. Sreenivas, if you can't, maybe I can bring up my screen and are you able to bring up the slides?
1 minute, I have to exit the full screen. Dr.
Yes, probably.
Anand, can you? I got it now.
Yes, right, you got it. So we're talking about high bleeding before, and I just wanted to let you know about the Onyx 1 global study design, which was presented last year at TCT 2019 in San Francisco by Dr. Windecker. Stefan Windecker has shown that high bleeding risk patients who undergo PCI, when they were randomized either to Resolute Onyx, the daughter-alignment eluting stent, with 1 month DAPT, versus BioFreedom, which because BioFreedom is a polymer-free drug-coated stent that has been studied against bare metal stents and leaders-free, so that is what is thought to be the best stent in high bleeding risk patients. So this randomization was perfect. 1:1 randomization. 84 global sites and completed in September 2018 and presented at 2019 with 1-year data. The primary endpoint was cardiac death, the myocardial infarction or stent thrombosis at 1 year. The secondary efficacy endpoints are target lesion failure, cardiac death, target vessel MI, and CLR at 1 year. And other secondary endpoints were lesion, device and procedural success rate, mark bleeding, and individual components of primary endpoints as well. Next. We can see that in people who are included, I mentioned elderly people more than 75 years contributed about 2/3 of the population, and some of them also, 1/3 of them had oral anticoagulation, anemia, renal failure, active or recent cancer, planned surgery. These are the type of patients that we actually discussed about today, and expected DAPT compliance, and some of them had thrombocytopenia and severe liver disease. So mean criteria was 1.6 per patient, and 46% of the patients met more than 2 HBR criteria. Next one. So here we can see that the majority of the people stopped the dual antiplatelet therapy at 1 month, and only single antiplatelet agent is continued at, in about 92% of the patients in blue. And actually you can see that up to at end of 1 year, 88% of the patients were on aspirin. Majority of them were on aspirin, 56.8%, and 43% were on a single antiplatelet agent, which is P2Y12 inhibitor. So this is really excellent data that we have shown. And at the end of the 1 year, the primary safety endpoint and component, cardiac death, MI, stent thrombosis, primary endpoint, and their individual endpoints, there was no difference, statistically significant difference between the two. In fact, if you look at stent thrombosis, in the blue is the Tonix, it actually did better than BioFreedom drug-coated stent. And next on, we can see there's a sub-study with the OCT in about 15 patients, and looking at the stent strut coverage. There's 86% of the stent struts were covered, and the surface is covered in 92% of the patient. So only 5% of the patients malopposed the stent. What is malapposition and why stent strut coverage is important? Having thinner stent struts as Resolute Onyx, and actually having a biocompatible polymer helps the tissue to come and cover it, and so the stent struts are not exposed to the blood flow, and thereby creating some platelet aggregation and stent thrombosis in such patient. And the more larger the stent struts are, there may be a neointimal hyperproliferation, which also is probably contributed by the polymer itself. So you need to understand that there are several components. We see in the next slide that of a drug-eluting stent, it is not just the metal or what it is made of, but also what actually is the drug. Sotolimus-eluting drug is an anti-proliferative drug, which is should be non-cytotoxic, and so that is what it is. It is cytostatic, and the polymer should not be an inflammatory polymer. It should be as much as biocompatible with and the thromboresistant, and so that is what we have in the Resolute Onyx stent. And the platform itself should be flexible, conformable, and as we have seen in several cases, complex PCI curved. I mean, these tortuous blood vessels. We should be able to deliver this stent. In the next, we can see that in this study, both BARC bleeding 1 to 5 and BARC 2 to 5 have been higher, more than 10%, but there's still no difference between Resolute Onyx and BioFreedom stent at all. And the major BARC 3 to 5 bleeding, as you can see, is much smaller, and still there's no difference between the two stents. And lastly, I just wanted to say that TLF is also similar, no statistically significant difference. In Resolute Onyx has been shown that in next slide we can see it has been shown that there is no difference in discontinuing aspirin on Plavix at 1 month and just continuing the single antiplatelet agent as compared to BioFreedom drug-eluting stent. In United States now and Japan, we'll be doing this Onyx Clear study, which is going to be looking at similar to Onyx 1, high bleeding patients undergoing on PCI. There's no limitations of the number of vessels or lesions, and we'll be evaluating in clinical outcomes, and actually that has been shown here in cardiac death, and MI at 12 months is at 7%. As you can see, cardiac death is still much lower, and the bleeding rates are also 3 to 5 years much lower, 4% or so. So to conclude, I think I would say that Onyx 1 has been a really great study, which in the past I used to do when patients have high bleeding risk, though without any much of a randomized controlled trial. I used to always use the Resolute, and if it was Resolute, I was comfortable saying to the patient that you can stop after 1 month. But what I was practicing with the small registry data now is supported by a large randomized controlled trial. And with that, I hand over now to Dr. Sreenivas Kumar. Thank you very much, Dr. Kumar, and all our panelists to join us on this evening.
Thank you, Ramesh, for showing the latest Resolute Onyx data along with Onyx Clear data. And that's how I think people are more confident even with 1 month DAPT therapy, especially in high bleeding risk patients. I wanted to just take your guidance and probably take all of our attention of the young cardiologists across the country as well as neighboring countries on this COVID challenge for cardiologists, which I made it as a challenge-based presentation, as well as now some people get some time. Caseload is less. Probably they can convert this free time to productive time. That's why I said as a challenge. Either they should upscale their professional skill or artistic skills, or learn some new instrument or knowledge, or publish, or become more healthier and fitter by doing more exercise, if not anything. So people who have achieved many of these probably will be awarded during the upcoming TCG India session. This is a word for people who are already busy. That's okay, but some places where the work is less, you could utilize this opportunity to make it more productive. I think thank you again. We'll have some brief discussion before we conclude, as we are already running behind the schedule. Any final we can get all of them again. I thought we had get all of them back on the screen. Okay. I think all the presenters did excellent job, shown very good cases, and in spite of the tough times in Bangladesh and Sri Lanka, Nepal, various other places, excellent cases were shown. Thank you, everybody. And before we conclude, final words for each of the panelists. Dr. Pandula, you want to say anything?
Can you hear me? Yes, I'm online. Hello.
Yeah, we can hear you. Go ahead.
Was there a question for me?
No, I'm saying the chat questions will you take then? Otherwise.
Yes. Okay. All right. Let me just have a look. Questions.
No. Like we have scheduled yes, about to become 9. Final few words before we conclude. Each of you can take a minute or so to express whatever you feel on it, whether on about your case or any other cases or any topic. Not able to hear me, I think. Rahul?
Yeah, so I think overall, all the cases, I think everybody has shown different aspects of high bleeding as well as complex cases, and some excellent, like with normal coronaries and those unusual kind of things. So I think overall, all the cases were quite good. A lot of learning from each other by sharing of these cases, and good data presented by Dr. Ramesh. So as I think everything was good. So.
Dr. Vinta? Unmute yourself. Not able to hear you?
No.
Can you hear me?
Yeah, we can hear you. Go ahead.
Yeah. Thank you very much, sir, giving me the chance to present in this precious moment and to participate in this very valuable event. Congratulate all the presenters and the panelists to present very beautiful, complex cases. Keep it simple, and the complex became the simple. Thank you very much, and I want to congratulate all of you.
Thank you, Vinta. Dr. Saidar? Dr. Saidar Rahman?
Yeah, can you hear me now?
Yeah.
Can you hear me?
Yeah, we can hear you.
Okay. Yeah, okay. In this pandemic era, also this is a very good session, and just for on its one, I just want to see another some coming trials to come. Is comparing just 1 month DAPT or also comparing with 3 to 5 months DAPT. So that one will be also interesting one because sometimes we are really confused to just stop the DAPT just for 1 month or we because sometimes we are dealing with the HBR cases according to criteria, some criteria, or sometimes after PCI the patient may come in HBR case. So there is also a concern here. And another concern is the SAPT that followed by the DAPT. So whether you put only the aspirin or you put the T2Y12, there is no clear that it is according to the physician's discretion. But you know that more potent T2Y12 inhibitor or the aspirin. So that one is also a big question. So this clarification should be done by the bigger trials, which I will expect later on. Thank you very much.
So, being with the clinical trial as quite complex for diabetic subsets, the patient was shifted on to a single antiplatelet. It was not aspirin, it was on to ticagrelor. Because it is more potent antiplatelet, we are comfortable leaving patients on P2Y12 inhibitors, whatever it is. If it is high bleeding risk, maybe clopidogrel. But here, about 50% plus you are an aspirin. In spite of that, Onyx data showed quite good. And we should appreciate the guts of Medtronic and they have the confidence on this Resolute Onyx platform. I think fortunately all the patients did well. That's the beauty of that gives us confidence also that even if we leave this patient in aspirin, still it is okay. But in my personal practice, if there's a bleeding risk, we thought we will stop aspirin and put the patient continue on clopidogrel rather than aspirin alone because of whenever you find a high bleeding risk. Bleeding risk is not there, probably we need to continue patients on ticagrelor. I think Dr. Sarita, any final comments? You have to unmute yourself.
It was a lovely session, and all the presenters have done a wonderful job, and the cases were exemplary, and it has been a great learning experience and also skill level which all the presenters have shown. And comments from Dr. Sreenivas, Dr. Ramesh, they are very well appreciated. So thank you so much.
Chandra, any final comments?
Dr. Dagapati, thank you so much for giving us the opportunity to present some of the work during this time. And I want to thank the organizers and all the case presenters for wonderful learning interactive experience. And we also have to thank the hosts for coming up with a platform to share knowledge and experience among regional players in cardiac categories across South Asia. Thank you so much.
Dr. Ramesh, over to you, Ramesh, for your final comments before we give it to Medtronic.
Chandra was trying to say something. I just want to thank everyone for the effort that you have put in for showing these wonderful patient cases. And thank you very much for Medtronic for helping us get on the webinar. Thank you.
Yeah, thanks, Ramesh. Before anybody asked me what is the best quality of Resolute Onyx stent, I always used to tell them, but probably whenever you have calcified lesions, difficult tracking, or where you find it could be difficult to place the stent, I used to probably tell them that is the greatest asset where the NC balls won't go, but this stent would track. Other advantage in left main type of lesions is differential expansion of the stent. Again, with a different anatomy, that always get good results. Side branch access was also good whenever you're putting it like a stent main across the LCH. We never get into trouble by complications of occlusions of the branch, provided there is not much of osteolysis in the branch. And then now we have a very strong data coming up that even with a short DAPT with 1 month anticoagulation, patients do well without much of a problem. In spite of very high risk subsets, the event rates were much less in the Resolute Onyx. Though you have to understand the 15% may look more, but you are dealing with a very high risk subsets of patients whose average age is 75 years plus, and nothing was excluded. Patients had all had complicated lesions, stent average length was more than 36 mm. In spite of all the complex subset, the dual antiplatelet, one change to one antiplatelet, including aspirin, patient did well. I think that gives us the clinicians a lot of confidence on this stent platform. We thank Medtronic for getting it to us. And initially, when we in the earlier part, we were not having that stent in the country. I pushed it very strongly, and actually, Medtronic again was kind enough to give this finally to get it back to our country. Now, I think many of our physicians start using it. I think with these words, I will close the session, and the final words of voting thanks and final comments from to Medtronic and Dr. Ravi or who is doing it. Anand?
Yeah, Ravi, you're there in line, right? Ravi, go
Yeah.
ahead.
Dr. Sreenivas, Dr. Ramesh, thank you so much for making this program happen. Special thanks to Dr. Sreenivas Kumar and Facts Foundation. When we went with this proposal of conducting the South Asia Cardiac Conversations, Dr. Sreenivas has accepted it very with great willingness, and we could have this program today. I thank each case presenter for taking out their valuable time and being a part of this discussion. Thank you so much. Thanks for the confidence you have in Onyx and Medtronic. Thank you so much. Stay
Thank you so
safe.
much.
Bye-bye.
Thank you.
Thank you.
Thank you very much.
Thank you very much.
Very much.